السلام عليكم. Next will be Dr. Ghada Samir, MRI in arrhythmia and repeated syncope.
أنا بس عايزة هو هتظهر ولا؟ Good afternoon, everyone. Today I'm going to discuss the MRI in arrhythmia and recurrent syncope. مش بيدوس لي بس. خلاص جامد. First, the definition of the syncope will be the total loss of consciousness due to cerebral hypoperfusion and characterized by a rapid onset, short duration, and spontaneous complete recovery. The European Society of Cardiology classified the total loss of consciousness into traumatic causes and non-traumatic causes. As regards the non-traumatic causes of the total loss of consciousness, they can be reclassified into syncope, epileptic seizures, psychogenic, and other rare causes. However, syncope is by far the most common cause, and it includes different causes like orthostatic hypotension, reflex syncope, and cardiac causes. And today, I will concern about the cardiac causes of the syncope. The American Heart Association and the European Society of Cardiology classified the cardiac causes of syncope into arrhythmic conditions and vascular and cardiac structural non-arrhythmic conditions. As regards arrhythmia, as a cause of syncope, it is the primary cause of a syncope, and it may be inherited, for example, like Ghada syndrome, or an acquired structural cardiac cause. A structural cardiac cause with any focus of fibrosis may be a cause of arrhythmia. Another causes of syncope will be وانا عندي مشكله في البتاع ما انا بدوس بس هو تقيل او مش بيرضى من تحت وفي ماشي خلاص تمام. As regards the structural causes, it may be aortic stenosis, hypertrophic cardiomyopathy, cardiac masses, pericardial diseases, and congenital anomalies of coronary arteries. And this category mainly depend on decreasing the cardiac output. Also, cardiopulmonary and great vessels causes may be pulmonary embolism, acute aortic dissection, or a pulmonary hypertension. Today, I will talk about the role of MRI and how can MRI help in the clinical scenario. First of all, the pattern of the role of MRI in arrhythmia is important in determination of the etiology of the arrhythmia, because the pattern or the regional or the diffuse pattern of myocardial fibrosis detected by the late gadolinium enhancement, or even a very early fibrosis detected by the T1 parametric mapping, enable us to determine which type of arrhythmia is seen in the myocardium. And also it can detect the adverse effect on the cardiac function or cardiac structure to guide the planning. Conversely, a normal MRI, you can provide a relative reassurance for the patient to focus the shift to another causes of arrhythmia that's not related to the myocardial disease. Variable structural causes of arrhythmia can be detected by MRI. For example, you can detect by MRI the ischemic heart disease, the dilated cardiomyopathy, the hypertrophic cardiomyopathies, the arrhythmogenic cardiomyopathies, cardiac amyloidosis, inflammatory cardiomyopathies, or myocarditis, and valvular heart disease. As for example, the ischemic heart disease, any previous myocardial infarction is can be a cause or a substrate for a cardiac arrhythmia, especially the ventricular arrhythmias, and it can provide an adequate assessment for the cardiac volumes, the ejection fraction, and the extent of the myocardial infarction on the LGE images. And they found that the left ventricular ejection fraction is considered the most reliable predictor for a future cardiac events and cardiac arrhythmias in such group of patients. For example, this patient, this is an image for the patient with late gadolinium enhancement and a myocardial infarction. You will notice that how MRI can detect precisely the extent of the myocardial infarction. For example, in this first image, this is amid a mid-ventricular short axis view with a subendocardial infarction below 50%. The second image is a subendocardial infarction between 50 to 75%, and the last image shows a transmural infarction that's more than 75% with an apical thrombus. Also, the dilated cardiomyopathy, patients suffer from a significant burden of an atrial and ventricular arrhythmia, and the presence of fibrosis on the LGE, which is usually mid-wall enhancement, strongly predicts the such cardiac arrhythmogenic events. Also, it can predict the ICD implantation and other cardiac events. Elevation also of the myocardial T1 mapping, T1 values, and the elevation of the extracellular volume that's not detectable on LGE has been associated with increasing risk of the ventricular arrhythmias and can potentially improve the risk stratification for such a group of the patient. For example, this patient has a sustained ventricular tachycardia on the ECG strip here, and this is a late gadolinium enhancement that is mostly typical for the patient with dilated cardiomyopathy, where we found a mid-wall enhancement at the site of the septal basal wall. In HCM, ventricular arrhythmia, particularly non-sustained ventricular tachycardias, are a common finding. An MRI also not also confirms the diagnosis, but it can precisely and reliably measure the maximum wall thickness, which is considered an important 5-year risk parameter for patients with sudden cardiac death. And also, it can detect the systolic anterior motion of the mitral valve, which can be added as a structural cause of syncope with such a group of patients, and it decreases the cardiac output. LV apical aneurysm also can be detected by MRI, and it affects the patient risk stratification. And also MRI is important in detection of the pattern of LGE in such kind of patient like patchy and mid-wall enhancement, mainly at the RV insertion points. For example, this patient also has a first-degree AV block, and the MRI shows an anteroseptal wall hypertrophy with patchy fibrosis at the anterior right ventricular insertion. AF is the most common arrhythmia in the patient with HCM, and so increasing the left atrial volumes and also the impairment or decreasing of the left atrial strain and ejection fraction, which can be measured also by MRI, has been proven as a strong predictor and determinants for the AF. The arrhythmogenic cardiomyopathy causes a regional and a global ventricular dysfunction, and it predisposes the patient to life-threatening ventricular arrhythmia. So MRI can play a role in the prognostic stratification for such patient and identification of how ventricular systolic dysfunction, how much the systolic dysfunction occurs. Also, it can detect the dyskinesia or the presence of aneurysms, the amount or how much fibrofatty infiltration is present, the LGE, which is usually transmural in the thin wall of the RV, and mid-wall or subepicardial in the LV walls, maybe at the lateral wall or the septal wall. And also the T1 mapping, elevation, and the impairment of the myocardial strain can detect the early diffuse fibrosis in the patient with no LGE, and this also predicts the early detection of the patient of arrhythmogenic cardiomyopathy. As regarded, the CMR can also help in the diagnosis of valvular heart disease that leads to arrhythmia, for example, arrhythmic mitral valve prolapse, which is characterized mainly by the myxomatous degeneration of the valve leaflets, which is represented by the valve thickening, also bileaflet prolapse, mitral annular disjunction, and papillary muscle fibrosis. The mitral annular disjunction is defined as a wide separation between the left atrium mitral valve junction from the left ventricular free wall, and such elevation or such separation result in myocardial curling and fibrosis, which act as an arrhythmogenic substrate. For example, this is how much the CMR is helpful in the case of the mitral annular disjunction or arrhythmic mitral valve prolapse. This is a case of the CMR in a patient presented with a bileaflet This is a bileaflet prolapse with anterior and posterior mitral valve prolapse, and you can also measure the distance. Also here you can assess the mitral valve regurgitation, and we can quantify the degree of or how severe the mitral regurgitation is. You can also estimate the distance of the mitral annular disjunction. You can measure the curling or distance between the basal wall. You can measure the distance, how curling is the myocardium is. Also, here we can measure the difference between the basal and the LV thickness ratio, the myocardial fibrosis, and also the myocardial strain, which is dropped or decreased in the cases of arrhythmic myocardial prolapse, mitral valve prolapse. Shortly, the other rare causes for structural causes of the syncope may be anomalous courses of the coronary arteries. Here's a patient with an axial gradient MRI sequence that shows a malignant course of the RCA running between the aorta and the pulmonary artery and with a slit-like appearance. Other vascular cause for a syncope is pulmonary embolism. As in this case, that we find that there's a hypointense filling defect in the pulmonary arteries. Also cardiac masses and their effect on the hemodynamic of the heart and how they can affect the relation between the mass and the outflow tracts and the valve orifice. Also the accumulation of the pericardial fluid, which lead to decreasing interventricular filling and stroke volume. And finally, the aortic dissection using gradient sequences of the MRI may be as a cause of vascular syncope. So just to sum up, the cardiac syncope is related to variable cardiac arrhythmic and non-arrhythmic causes. The CMR is capable of determining the etiology of arrhythmia, so identification of the pattern of myocardial fibrosis using LGE and T1 mapping. Also, the determination of the adverse effect on the heart function, the heart structure, and how we can use this in guiding the management. And also, cardiac MRI can determine variable cardiovascular causes of syncope. Thank you.
Thank you, Dr. Ghada. Any question? في حد عايز يسأل حاجة؟ طيب, move on to the next